Good morning. Today we shall discuss the uterine tubes. They are also called the fallopian tubes or the salpings. Now, they are tortuous ducts which are conveying the oocyte from the ovary to the uterus. The spermatozoa introduced into the vagina pass up the uterus and from there into the uterine tube. Fertilization takes place in the lateral part of the uterine tube. It is situated in the free upper margin of this broad ligament over here. It is about 10 centimeter long. At the lateral end, the uterine tube opens up into the peritoneal cavity through the abdominal ostium, which is about 3 mm in diameter. The subdivisions. The lateral end of the uterine tube is shaped like a funnel and therefore it is called the infundibulum. Right? Infundibulum. Now, this infundibulum bears a number of finger-like processes called the fimbriae. Therefore, it is called the fimbriated end. So, one of these fimbriae is longer than the others and is attached to the tubal pole of the ovary. This is called the ovarian fimbriae. The part of the uterine tube medial to the infundibulum is called the ampulla. It is thin-walled, dilated and tortuous, forms approximately the lateral two-third or 6 to 7 centimeter of the tube. Now, it is arching over the upper pole of the of the ovary, This ampulla is about 4 mm in diameter and this is the site of fertilization. The isthmus succeeds the ampulla. Over here, it is narrow and cord-like. This is the uterine tube isthmus. Forms approximately medial one-third or 2 to 3 centimeter of the tube. The uterine or the intramural or the interstitial part of the tube is about 1 centimeter long and lies within the wall of the uterus. It is opening at the superior angle of the uterine cavity by a narrow uterine ostium. This ostium is about 1 millimeter in diameter. Here you can see this is the fimbriated end, infundibulum of the uterine tube, right? Then we have the uterine tube, the ampulla portion, right? And then this is the uterine tube isthmus part, and this is the intramural part of the here uterine tube, the intramural part of the intrauterine part. Now, basically the isthmus and the adjoining part of the ampulla are directed posterolaterally in a horizontal plane. Near the lateral pelvic wall, this ampulla arches over the ovary, as you can see over here, and is related to its anterior and posterior border, upper pole, and the medial surface. The infundibulum projects beyond the free margin of the broad ligament. This is more clear in this picture. The uterine tube lies in the upper free margin of the broad ligament of the uterus. This is the broad ligament. The part of the broad ligament between the attachment of the mesovarium and the uterine tube is called the mesosalpinx. This is the mesosalpinx over here. It contains the termination of the uterine and ovarian vessels and the epiphyron. Blood supply. The uterine artery supplies approximately medial two-third and the ovarian artery supplies the lateral one-third of the tube. The veins run parallel with the arteries and drain into the pampiniform plexus of the ovary into the uterine veins. The lymphatic drainage. Most of the tubal lymphatics join the lymphatics of the ovary and drain with them into the lateral aortic and the preaortic nodes. The lymphatics from the isthmus accompany the round ligament of the uterus and drain into the superficial inguinal nodes. The nerve supply. As you can see, the uterine tubes are supplied by both sympathetic and the parasympathetic nerves running along the uterine and the ovarian arteries. The sympathetic nerves from T10 to L2 segments are derived from the hypogastric plexus over here. They contain both visceral efferent and efferent fibers. The latter are vasomotor and perhaps stimulate the tubal peristalsis. However, peristalsis is mainly under hormonal control. The parasympathetic nerves are derived from the vagus for the lateral half of the tube and from the pelvic sphincteric nerve from S2 to 4 segments of the spinal cord for the medial half. They are inhibiting peristalsis and produces vasodilatation. Now, inflammation of the uterine tube is called salpingitis, and sterility is inability to have a child. The most common cause of sterility in a female is a tubal blockage, which may be congenital or caused by any infection. Now, the patency of the tubes can be investigated by an inflation test or the Rubin's test. Normally, air is pushed into the uterus, passes through the tubes, and leaks into the peritoneal cavity. This leakage produces a hissing or bubbling sound which can be auscultated over the iliac fossa. But nowadays, a radiological technique, that is the hysterosalpingography, is used, in which the cavity of the uterus and the lumina of the tubes can be visualized after injecting a radio opaque oily dye into the uterus. Okay, so what is a tubal pregnancy? Sometimes the fertilized ovum, instead of reaching the uterus, adheres to the wall of the uterine tube and starts developing over here. So this is called the tubal pregnancy. Enlarging embryo can lead to the rupture of the tube. Tubectomy. For the purpose of family planning, a woman can be sterilized by removing a segment of the uterine tube on both sides. This can be done laparoscopically or through an incision in the abdominal wall. You can see the fallopian tubes, they could be banded, cauterized, tied, or cut. See, the transport of the ovum is chiefly due to muscular contraction of the uterine tubes. The ciliary movements create an effective stream of lymph towards the uterus, which assists in the nourishment of the ovum in the lumen of the tube over the mucosal ridge. Right, so that's all about the uterus, the uterine tubes. Thank you.